Yeah. This session is being recorded, and the recording will be shared on our YouTube page, and the link will also be shared to everybody that attended the session. Afterwards, a certificate of participation will also be shared to those that joined the webinar. So right now, I would like to begin with our first speaker for the day, in person of Dr. Kuman Wilson, and I would like to read his biography before I proceed. Dr. Kuman is the CEO and Chief Scientific Officer of Breyer Health Research Institute and the Vice President of Research and Academic Affairs at Breyer Health. His research focuses on digital health, health data, immunization, pandemic preparedness, and public health policy and innovation. Kuman is also a specialist in general internal medicine at the Ottawa Hospital and a full professor and Faculty of Medicine Clinical Research Chair in Digital Health Innovation at the University of Ottawa. He is the co-founder and chief scientific officer of Can Immunize, a science-based technology company specializing in immunization software. He has received support from multiple organizations, including the Canadian Institute of Health Research, the World Health Organization, the Bill and Melinda Gates Foundation, and Canada's Immunity Tax. So right now, with so much excitement, I would like to invite Dr. Kuman Wilson. Thank you very much for accepting to speak. You now have the floor.
Are you able to see my slides?
Yes, we can.
Okay, great. Thanks. Okay, well, thank you for inviting me to speak today. I am grateful that you picked this topic. I think it's a topic of substantial importance, the impact of nationalism on global health governance. I had actually been thinking about this during the pandemic, and I've written a couple of papers, both for academic and lay journals, examining how populism was impacting the response to the pandemic. And what was clear was the international health regulations in particular weren't functioning the way we had hoped them to. And one of the major components to that, I believed at the time, was this brewing populist sentiment. We'd actually seen signs of this much earlier. Many of you are probably familiar with this issue that happened around the time of the H1N1, or prior to the H1N1 pandemic, when strains of H5N1 were circulating in Southeast Asia. And there was this issue where Indonesia had lost some level of trust in the global governance regimes, and instead of sharing their viral samples with the WHO, had made an independent deal with Baxter. And the reasoning for that is they didn't believe they would get any vaccine at an affordable price back from the WHO and pharmaceutical companies in the existing arrangement. They eventually did rejoin the global arrangement, but it did demonstrate that there was distrust at the local level of how exactly reciprocal these global governance regimes were. And I live in Ottawa, Canada, and we had to deal with this during the pandemic. This is the trucker protest. And it really was a manifestation of populist sentiment and distrust in decisions made by what were perceived to be unaccountable elites and as part of a global governance regime. And it obviously was very disruptive for us here in Ottawa. And now we're seeing the culmination of this in certain respects, unfortunately, as a populist government in the US has withdrawing the U.S. from global health through the cuts to U.S. aid and threatening full removal of themselves from organizations such as the WHO. And there's a risk of this spreading to other populist governments throughout the world. So it's something we really need to take seriously and figure out how to address effectively. And in general, we're starting to see this shift from the globalism that was part of the post-World War II world order that emerged, and back much more to a sort of World War I world order of very focused on individual countries as opposed to international arrangements. So first, a definition of what is populist sentiments. And populism refers to movements which appeal to local populations who believe their needs are not prioritized by ruling elites. An important aspect to why populism is arising is the engagement of nations in international agreements, the climate accords, the multilateral trade agreements, intergovernmental institutions like the UN and the WHO, and transnational alliances like the EU and NATO. And in the UK, Brexit was a manifestation of some of these concerns that were occurring about these arrangements. I have a picture here of the World Economic Forum, often the target of populist ire, and it sort of encapsulates the concerns of populists that these regimes are subordinating the interests of nation states to those of the international community, and that the national populist does not have a voice in the decision-making processes, but unaccountable elites are making decisions on their behalf. And that brings us to the international health regulations, national sovereignty. Other health experts have commented on how radical the revisions in 2005 were vis-a-vis state sovereignty, and the IHR imposed requirements on state parties to report potential public health emergencies and develop the capacity to report and respond to them. And also, fairly significantly, it gave the WHO the authority to conduct independent surveillance on these agents, on these countries for potential public health emergencies of international concern, and report this information to other affected countries, and to issue recommendations such as trade and travel advisories. And it also permitted adjacent countries or neighboring countries to report on other countries. So from many perspectives, this was viewed as fairly radical revisions with respect to, compared to other international arrangements on the level of obligation that it imposed on state parties. But like most, while it was legally binding, like most international agreements, there were really no formal penalties associated with non-compliance. And that's important because there are significant disincentives for compliance. So low and middle income countries argue that they lack the resources to necessarily fulfill the agreement's mandates. And the perception that this is really designed for wealthier countries, and that lower income countries were basically asked to function as early warning systems so that wealthier countries could then mobilize their resources, close their borders, take matters to protect their own population. And even large and middle income countries also had concerns about this because of the economic impact of some of the measures on their population. And the issue really for lower and middle income countries, particularly I think in your region, is that there are domestic public health threats that require resources such as HIV, tuberculosis, malaria. And was the IHR basically asking countries to redivert resources from tackling these challenges to basically functioning as an early warning system for higher income countries? And part of the legitimate concern in this regard came from the fact that there was a past examples of potentially unjustified trade and travel restrictions being imposed upon reporting countries. So you were actually the disincentive to report. So and this is sort of how the IHR intersects and perhaps enhances populism by its impact on national sovereignty and triggering these populist concerns at the local level. And COVID-19 really brought some of this to the forefront, as there was a lot of skepticism at local levels about some of the measures being advised, and the impact on the local populace and the economy in particular. So compliance with the IHR has the potential to trigger two kinds of populist resentment. And these relate to essentially the impact of notifying events. And the reality I think people need to realize is at the early stages of any potential identification of event, there is uncertainty, and some judgment needs to be made on whether you report or not report. While there is an instrument in the IHR to guide, it does still require some level of discretion. And the national focal point is expected to report such events, but here we run into issues of horizontal governance. Other ministries who may not be as familiar with the IHR, who have other concerns, for example, agriculture and such, may feel that you shouldn't report these events. They may be the one that actually get the information about the events, for example, a foodborne illness or such. And they have a real incentive not to communicate this. They may not even be familiar with aspects of the IHR. And we did a project for the WHO to actually look at this specific issue. And here there'd be concern that if the state party went ahead and reported, and it had a real negative impact on some of those local industries, trade, travel, agriculture, for example, this could stoke populist resentment. And then there are also issues of vertical governance as well, where the IHR is in agreement with the national or federal government, but often the implementation occurs at the subnational level. And these IHR requirements need to be executed at the state, provincial, canton level. And these state, provincial governments they respond often to their local electorate, and they may be disincentivized to feed this information up, particularly if their local populations see this may adversely affect them. And so, again, this can trigger populist resentment at the local level. And a lot of this came, again, to head with COVID-19. There was a distrust of the WHO and the global approaches to managing pandemics. And there were concerns at the early stages about how the WHO reported the outbreak in Wuhan and whether it waited too long to report on it and declare a public health emergency and not calling for what was perceived to be needed travel restrictions. And what was apparent was that the WHO actually said we shouldn't have, to the IHR, they shouldn't be having travel restrictions. Virtually every country in the world exceeded the WHO guidance, and that was an example of how the IHR didn't function as intended. And then populist governments, in particular at the time, United States, Brazil, and UK, in particular, were reluctant to follow the WHO guidance and in times called out the WHO specifically. And there was legitimate criticism to be had of some of the guidance provided by the WHO at the time. So this is not to say that the populist sentiment is invalid. It's just that it was disruptive to the intent of the IHR and the global governance regime. So what is the best approach to managing the populist threat to the IHR and global health governance in general? I think there's some opportunities that the IHR global health has that other international regimes don't have. The benefits of these global health governance regimes are more tangible. So the climate accord, for example, you're asking for an immediate sacrifice for a longer term trade-off benefit, longer term benefit, but you're managing public health threats is very tangible. and providing assistance to manage the public health threats demonstrates a commitment to the local populace in these countries, and that really needs to be made more evident. As well, the local population can be really negatively affected by public health emergencies. So there is more of an argument for them to participate than they may see, for example, in a free trade arrangement or in an environmental accord. So some just thoughts we had at the time. They're concerned about transparency, about decision making. The Annex 2 is very clear on how decisions are making, but ultimately the declaration of a public health emergency and the subsequent recommendations is made by the Director General with the Emergency Committee, and sometimes it's unclear how these decisions are made. So transparency was always a great approach to diffusing some of this populist sentiment. More visibility and the tangible support that WHO and global health regimes provide to state parties and to local populace would be valuable. And then people will see that this social contract, the reciprocal nature of this arrangement and the benefits of it. And something we've argued and has been argued in the past is the creation of a compensation fund for countries that are adversely economically affected by doing the right thing and reporting on potential threats. And generally, as well, at this country level, the country has a responsibility to communicate to its local populations that what is the purpose of their engagement in this regime, and how it really is intended to not only protect global health, but protect their own populations. And sometimes this communication doesn't occur, and it's this perception that the so-called elites are not interested in these local issues that fuels the resentment that results in the emergence of populist concerns. There are others on the call that can talk more knowledgeably about the recent developments, but there have been two dramatic recent developments, the IHR amendments and the pandemic treaty. And the IHR amendments include introducing a definition of a pandemic emergency. Hopefully that improves transparency, but we need to see how that gets operationalized. There is a general commitment to solidarity and equity, including a creation of a coordinating financial mechanism to support those that need help in developing their core capacities. And again, we need to see how that gets operationalized. There's a committee call for the establishment of a committee to facilitate implementation of the regulations, and actually some of the work we did with the WHO resulted in this call for the creation of a national IHR authority to help with horizontal governance, to help the other ministries understand why the IHR are so important. And I know the others will be talking about this, but the pandemic treaty is a historic moment. And a key component of it is this pathogen access and benefit sharing system, which comes back to how this sort of all started with the Indonesia issue. It's still under negotiation, but it will govern how countries share their biological materials and ensure that they get vaccines and diagnostics and therapeutics in return. And there's legitimate concerns about this, because my sense is that the lower income countries got the COVID vaccines last, and they got the H1N1 vaccines last. So there are real arguments for this isn't really working for them. So I'm hoping that this agreement can address those concerns materially. So just to conclude, global health governance has made a dramatic impact on how the world responds to these threats. Its impact is not just on health, it's on the economy and preserving trade. And we need to take steps to make sure that this is apparent to all. So highly transparent and positive local, national, and global responses to international health threats through the IHR and potential pandemic treaty can help assure global health security, and we need to do this in a way that's visible to local populations. And we're in an exciting time here. And if we can do this right, instead of stoking populist concerns, the current efforts could alleviate these concerns by demonstrating the tangible benefits of participating in the global community. Thank you for that. I'll pass it back to you.
Okay, thank you so much. Thank you so much, Dr. Kuhlman-Wilson, for that beautiful presentation and for opening the conversation with such clarity. You took us through what populism is and the steps we could take. And majorly, you emphasized that transparency and accountability is important whenever we are addressing global health issues. So thank you very much. Because of our time, I would like us to move on to the second speaker for the day. I would also like to thank our participants who are just joining. In case you're just joining, thank you for joining us. Kindly input your name and wherever you're joining from so we can greet you. And then if you have questions, please direct them to the Q&A session and it will be addressed after the presentations. So the next speaker we have is our expert here from Nigeria, Professor Oyewale Somori. Professor Oyewale Somori is one of the most respected public health experts here in Africa. And I would like to read his biography before I proceed. Professor Oyewale Somori received a Doctor of Veterinary Medicine degree from Ahmadu Bello University, Zaria, and a doctorate degree, PhD in virology from the University of Ibadan, Oyo State, Nigeria. In 1981, he was appointed as a professor of virology at the University of Ibadan. The same year, he received the United States Department of Health and Human Service Public Health Service Certificate for his contributions to Lassa fever research. 3 years after his appointment as a professor of virology, he was appointed the head of the Department of Virology. At the University of Ibadan, Professor Somori's research interest focused on viral infections, including Ebola, hemorrhagic fever, yellow fever, and Lassa fever. He served as the regional virologist for the World Health Organization Africa region between the year of 1994 to 2004. He was appointed the pioneer Vice Chancellor of Redeemers University, Ogun State, Nigeria, a tenure that ended in 2011. As the regional virologist, WHO African region, from 1994 to 2004, Professor Tomori works was instrumental in setting up the African Regional Polio Laboratory Network, a network of 16 laboratories that provided crucial diagnostic support to the Global Polio Eradication Initiative. This network, which later became the model for other regional diagnostic laboratory networks for measles, yellow fever, and other viral hemorrhagic fever, was a testament to his dedication to public health. He was also deeply involved in the investigations of outbreak of viral hemorrhagic fever, Lassa fever, yellow fever, Ebola, Marburg hemorrhagic fever, infections in Nigeria, Liberia, DR Congo, Uganda between 1995 and 2004, further underlining the impact of his work. Professor Tomori's contributions to the field of virology have been widely recognized. He is a fellow of the Royal College of Pathologists, UK, Nigeria Academy of Science and Nigeria College of Veterinary Surgeons. His work has been acknowledged with the Nigerian National Order of Merit, Nigeria's highest award for academic intellectual attainment and national development, which is a testament to the respect and admiration his work has generated. So right now, I would like to formally onboard Professor Tomori. Thank you so much for joining us and for accepting to speak. We truly do appreciate you. So over to you, sir. Thank you.
Thank you very much. Can you hear me?
Yes, we can.
Hello?
Perfectly.
Yeah. Can you see my slides?
Yes, we
Not
can
yet?
as well.
Yeah, I can't even see my slides myself. That's the problem here. I was looking at it, but I don't know where it is. Just a second. I'll get to you. I thank you for this invitation, and also, so you see my slides now. Thank you very much. I just want to move it on. Okay. So, what I want to say is the fact that I accepted this one not because I knew what I was talking about. I saw all these issues about populist nationalism and nationalist popularism and all those kind of things. So I then said, this is an opportunity for me to also learn. So I think you see my second slide is introduction. I hope you have seen it. Hello?
Yes, sir, we can see it.
Okay, so I'm doing the introduction now. I'm looking at nationalism and looking at populism. I'm sure many of you know about this, but for me, that I don't know too much about it, it's an opportunity for both of us to learn. So nationalism, populism, nationalist popularism, and populist nationalism, what exactly to all those things? And for us in Africa, what do we have? I think we have personal popularism, or what I call personality popularism. And are we going to maximize the impact and mitigate the opportunity, or maximize the opportunity and mitigate the impact? Because sometimes we don't really know what we're doing in Africa, and we think we are trying to mitigate, the impact, while in actual fact we are mitigating opportunities. And instead of trying to reduce the impact, we are actually maximizing the impact. So which way for us in Africa? Which way for us in Nigeria? And that's what I'm going to be talking about. You know all this already, what nationalism is all about. It is one which identifies one's own nation, and you do it to the exclusion or detriment of the other person. That's the extreme of nationalism. Basically, nationalism itself, I don't have any problem with nationalism, trying to get your country to do well. But when you do it at the expense and the exclusion of others, then that's the negative side of it. Populism is a political approach that looks to appeal to the ordinary people and divide us and say, oh, those who are in charge, they're not taking care of us, and you are disregarded by the established. But when I start talking about Africa, you begin to wonder who is the one that is disregarded by the authority? Who is the authority? Who are the we? Who are the us? And the leadership in many African countries is the one that we're actually all fighting against. So they're the one that should be fighting for us, are the ones we are actually fighting against. So when you talk about nationalist populism, it's also used to define a political ideology that looks to mobilize popular support within the country so that you can strengthen your nation. In a way, again, you can go to the other extreme of it, and which will become to the detriment of other countries. Then there's populist nationalism, which takes the two together, populism and nationalism and all that. So I asked a question: nationalist populism or populist nationalism, what do we have in Africa? Certainly, we have neither of those, because Africa is a continent, it's not a nation, it's not a nation. So what do we have in Nigeria? What do we have in any other African countries? Again, neither of the two. I think what we have is personal populism or popular personality, where the leader thinks is the nation. I think we need to prepare ourselves so that we know what our problems are, and before we start finding the solution of the West for a different problem in Africa. Remember, in Africa, what we have is neither nationalist populism or populism, whatever. What we have is personal populism, popular personality, in which the leader thinks is the nation. I mean, once you know that, because you don't know it, you are going to be finding a different solution. So this personality populism is focused on that personality. You see the traits of, not only Africa. Luckily for us, we have America joining us now. The traits and the style of the leader, his rhetoric and his demeanor. But this one has the opportunity to distribute your national resources as is a personal favor to help him stay in power. That's what we have in Africa. The purpose leader exhibits some of these traits: extraversion, which is focuses on gratification obtained for himself, narcissism, which excessive interest and admiration of himself. He has this strength, sense of self-belief, and he has tendency towards simplicity language, make Africa great, renewed hope as we have in Nigeria. The focus is trying to divide us and them. Unfortunately, they are the ones that actually the problem, not us. Now, let's move on to this thing. Africa has been impacted by all, both by nationalism, national populism, which has come from external source, populist nationalism, we also have come from, but the personality populism, which is internal, is actually a major problem. Why these other ones, like you find with COVID vaccine and others, and monkeypox fakes and all those things, and Trump tariff affecting us, there's more major problem within itself. Even if we take care of national populism and populist nationalism, if we don't handle the personality cult, the personality populism internally, all these things we are talking about will be nothing. We will not find a solution to it. We've heard about the impact of COVID-19 vaccines, nationalism, global this thing. But I have a question I'm going to ask you about this COVID vaccine, and when this attitude of us in Africa to think somebody owes us something. Somebody said that we are handicapped, we are whatever. But again, I don't believe we are handicapped. We're just this thing. But look at what happened with where PEPFAR was dismantled by on the left side. You see all the countries in Africa that depend on PEPFAR, one form or the other. Look at the there's no other person in Africa. You can just in the whole of South, the East, the West, all over. And then suddenly, when Trump decides that he was not going to give more money, there's this study which showed that 12.5% of the countries reported their ability to maintain service not for more than 12 months without the support. Which means without that support from the dismantling of this thing, many of these countries that they are showing this thing will not be able to maintain the support. Look at the situation with monkeypox. And again, we need to begin to know ourselves, study ourselves. Look at that map that shows what monkeypox are. Monkeypox was not declared a global health emergency until way after the problem has started in Africa for the last 50 years. Suddenly it gets into Europe, gets to the West, and it becomes a public health emergency. But even when the public health emergency was lifted, it was still raging in Africa. It was lifted in May 2023, and see what has been happening with COVID in Africa. These are some of the things I think we or us in Africa need to know, that we have an internal problem. The world cares little about us. We are to care about ourselves. And there are evidences showing that so nationalism is often a positive force, like I said, but it can be negative part of it. And we see that effect in monkeypox response in Africa. We see that in COVID response in Africa. We see that even in the Ebola that happened in 2014. So it leads to hindered cooperation, leading to delays in response. It took 3 months or more for the WHO to declare Ebola. It started in 2013 and not in March of 2014 before it was declared. But when monkeypox hit Europe, within weeks, it was declared the public health emergency. The existing health facilities are hampered, just like you saw with our colleagues in Africa who are depending on PEPFAR. If PEPFAR doesn't happen, then we're in trouble. Reluctance in sharing information, with our colleague who started the discussion mentioned that about and this new pandemic treaty, which is talking about, like, if I just put a note here, I said Africa has the pathogen, Europe has the benefit, but no, they want the pathogen, they don't want to give the benefit. So there's delayed vaccine distribution, and then we have reduction in trade. That's what nationalism comes to. So what must we in Africa do to mitigate this impact and maximize the opportunity? Remember, the impact is both external, from the nationalism outside, and internal populism, which is what our leadership are doing. To me, that's the most important area to do. So what must we do? We need to strengthen our public institutions. All these things I'm talking about require money, but I will talk about money later. We need to strengthen our public institutions. We improve our surveillance and reporting. And incidentally, the surveillance and reporting is our strength in Africa, but we disdain that. Why am I saying that? Years of epidemics in different parts of Africa for the last 50, 60 years. We have been investigating every disease that have been coming. We have gathered skill. We have become experts in it. Some of our own people have been sent out to other parts of the world, yet we will not put money on surveillance. We will not provide the resources for those who are doing surveillance, enable them to do what they are doing. And then we would rather wait for an epidemic to come, and then we start begging the world for vaccine, which we don't have any control over. We have control over surveillance, we have the resources, we have the human beings that can do it. We don't have vaccines. So why don't you put where your strength is and put money in there? We must empower our system to manage our data. We still find that waiting for, during the COVID, all the decisions that came out from the WHO based on data that they gathered in Europe. Yet we had all these death centers in Africa that could have managed their own data and not followed blindly the whatever it is that came out of WHO based on the data, which is not our own. Yet we have we can analyze our own data and take a decision on that one. Those are part of the surveillance reporting and data analysis I'm talking about. And it doesn't really cost that much money to do that compared to looking for vaccine, compared to controlling an epidemic. We must increase our domestic investment. That's what I'm talking about. Our capacity building. We talk about capacity building. We never talk about capacity retention. You build, and since I was born, which is almost 80 years ago, they have been doing capacity building. They even still calling me for capacity building at my age. But the point that we in Africa, we're not bothering about retaining the capacity we have. So we must mobilize resources and collaborate with private sector so that we create the enabling environment for our capacity that we have built to stay. And then we must begin to look at the issue. Of course, we're talking of vaccine, diagnostic, therapeutics. Why are we asking for Europe to give us ordinary, we're importing distilled water from Europe? These are issues that we need to begin to look at. So we must invest in our public health workforce, and so that and the leadership programs, and then we must build partnership. We cannot do it alone. But I'm not saying let them take over our duties. There are areas we don't have capacity for. Then that's where the capacity comes. I say we must invest in our strength. I said it. Years of handling epidemics. We have the core and the relevantly equipped and talented health workers who have the experience. I'm not sure any part of the world has the experience in investigating epidemics than Africans. This is the cake. It is now place to put an icing on it. Like I say, vaccine is the icing on the cake. But first, let's take care of our cake. Self-reliance. We must stop begging for aid and crumbs. Aid aids the aider more than the recipient. That even the Bible said it. I'm not the only one that said that one. We must reverse the legal transfer of our resources through accountable transparencies. And we must tap all our resources. No, stop limiting any. What did they call us? They said, I said we must create that enabling environment. I mentioned that again, and stem the issue of brain drain that is going on. And we must pray for good leadership. And that's the third part of which I'm talking. Finally, let me say one thing. We must stop addressing our problem. You say, oh, what is he talking about? I'm saying we have to undress our problem. Let me tell you a story. Then you know why we're saying that. The masquerade was hit by a loaded vehicle that ran amok. The trailer came, no brakes, charged down the hill and rushed, hit the masquerade, who was rushed to the hospital. He got to the hospital and the doctor went to examine. He said, oh, no, it's a taboo. You don't unmask a masquerade in public. So how is he going to get treated? So we need to address our problems, not address them. We have been addressing our problems all these 50, 60 years, even if I've been. We must address the issue. When we address the issue, we cover up the problem. When we undress the issue, we expose the problem. The masquerade had an accident, was rushed to the hospital. He refused to be undressed. And of course, you know what happened to him? He would die. AIDS is a bondage. It's like cancer, which is treated with Band-Aid. And look at that. You see, in fact, you see the chain is, it has the color of the giver. 66% of AU budget is sourced through non-member states. That's what the CBN reported. The AU headquarters in Addis Ababa was built by Chinese government. The African CDC was built by Chinese government. Is it that Africa is poor? Is it that we don't have money? Is it that we don't have resources? No, that's not the situation. Look at that map. There's no country in Africa that doesn't have something buried under the ground, which will be useful to the world. Something that, that you and I can use. What are we doing with all those ones? It talks about money that comes into Africa and money that goes out. Half of the money that we get in trillions actually goes out in illegal means, which is tax evasions and even the property, the IMF, the International Monetary Fund, which may have a different name. Anyway, International Mortgage Fund. So these are the kind of money that goes out of Africa. We need to address those issues. We see that out of 133 and 37 that comes in with the inflow, we have taken 192 of it goes out of Africa. These are issues that we need to begin to address. We have resources, but what have we done? We have made those resources and placed them on the dining table of expatriates to come and eat. Africa has become the menu on the table. Anywhere you go, and that's what is happening to us. Europe, America, everybody, they are busy there eating up Africa. And we are sitting down there, not making use of them. So what do we do with the resources we have? Those untapped resources, those unused resources, the ones we have not utilized, the ones we have added no value to, the ones we have looted, the ones we have stolen, the ones we have stolen. Where have they? They call us names, isn't it? They said this is a resource-limited setting. They talk about resource constraint. We are not resource-limited. We are resource squandering. We are resource wasting. And we are corruption constrained. Unless you know what your problem is, you'll never find a solution to it. See what happened when Trump can't dismantle this thing. My government approved $200 million to fill the gap that shut off on U.S. aid cuts. I asked the minister, I said, where was this money before Trump came in? And if Trump had not done it, what would we have used the money for? These are questions you'll be asking. I said, the money is there, but we're not using it. I fear donors. Look at that picture, shows you the relationship between the donor and the recipient. That's the donor hiding there, and look at the poor animal waiting. If he shows up there, it's going to be mauled by this thing. Africa, we have a wrong sense notion about equity. You do not beg or cry for equity, as we currently do. We fight, I'm not saying physically, with our resources, all those untapped resources I'm talking about, to negotiate for equity. To the equity table, when you come in there, you bring your raw material, you're going to get a raw deal. You bring nothing, you get things, or you get crumbs. And see, this is the picture they show us about equity and whatever. What we should be seeking is liberation, not equity, not equality. Is not. And then look at that. Let me go to the next slide. I will show you some of the things I'm talking. Liberty comes before equity. Africa must wake up. From the dominance of dependency and the clamor of equity. Our challenges are half century of lies we have told ourselves, and the wrong names that we are called and we will accept. It is important for us to decolonize ourselves. When they say think out of the box, ask yourself, who put me in the box in the first place? How did I get into the other box? Why am I still in the box when I can get out of the box and think seriously, not be under the outside of the bondage of the box? When they say you are resource limited or constrained, tell them it's a lie from the pit of colonialism. I am resource wasteful and I'm resource squandering. These are the messages. Again, I bring that up to show you that the world cares literally about Africa. And when I see what has happened with COVID, with Ebola, with this thing, and I hear of WHO, WTO, WRPRO, and have you ever wondered, all these things, do you think the W there stands for what? No, the W there stands for white, not world. Let's be frank with ourselves. So our strength, quickly, I'm going to go through. I mentioned that before, epidemics that did not happen in Africa. There are many of them. In Ebola in Lagos, you remember when it happened in Lagos in last year, everybody thought the whole world was going to collapse. In rural Kenya, in Ebola has crossed Uganda, DRC has handled this, and more recently, Rwanda handled Marburg. All these are expertise that occurred with, yes, of course, we had international support, but this was something was undone. These are years of epidemics that have been coming since 1969, monkeypox in 1970, Ebola in 1977. We have the experience, but we refuse to use the experience. We have the adequate human resources and the relevant experiences and the skill. All we do is that we disgain and discountenance this unique resource and start begging around the world for vaccine. We say Western aid to fight pandemic is backfiring. I won't go into all that detail. So let me conclude. We need to address the issue on our own ground. How can rancid poverty live side by side with decadent affluence? These are issues we're talking about. If we resolve this problem, then more of this will go around us rather than we depending on international aid. Look at that one. That's the house of somebody. On the right is a retired civil servant who managed to get a car which cannot ride again. On the left is a minister in the house of this. See the kind of discrepancies we're talking about. Disease will continue to spread in Africa as long as the emphasis is on vaccine, not on surveillance, not on case finding, not on isolating cases, not on contact tracing, and not on community awareness. All of this require much more little money than vaccines will do. Prioritizing investment in preparedness and surveillance is far cheaper and more cost-effective than clamoring for vaccines, and it saves more lives. So just to remind us again, about this. We need surveillance, we need isolation of cases, we need infection control and prison, and then all those kind of things. Our politicians, all the educated people, our scientists, we must improve the range of our contribution. It is a win-win situation when we get our society involved in what we are doing. My generation provided lab results within the 4 to 6 weeks, by which time the patient is dead. This generation is providing lab results within 2 to 4 days, by which time you can still save some people. The future generation, which is where Africa should be looking, they are going to provide laboratory results 24 hours before the patient is infected. And that's the direction Africa should be looking at. So, again, I won't go into that. How much vaccine are we getting anyway? And when shall we get the vaccine? A Nigella disease becomes the outbreak for increased gross domestic poverty. With the performance these past 50 years, our children should be angry with us, and rightly so. Thank you very much. My time is up. I appreciate you. Over.
Oh, wow. Thank you so much, Professor Tomori, for your always insightful and inspiring message. You've reminded us again that even in changing times, Africa has the capacity to change its own narrative in global health. And there's a few things you mentioned which I would like to re-emphasize. You mentioned that we need to strengthen our public health institute. We need to improve our surveillance and reporting. If we cannot go into vaccine, then our strength, which is surveillance and reporting, since we've handled a lot of epidemics the past few years, we have the expertise we need to work on our surveillance and reporting system. And you also mentioned that we need to empower system to manage data. Then you mentioned we need to increase domestic investment in health, capacity building, and capacity retention, which is very true. We need to look for ways, strategies to retain this capacity that we've built. It is not every time we continue to build capacity. Then we also need to expand local manufacturing and collaborate with private sectors for capacity building. So thank you very much for that beautiful presentation. We truly do appreciate you. So before we move to the next speaker, I would like to take a moment to introduce an important upcoming event to you, which is the 11th African Conference on One Health and Biosecurity. This Africa's premier biosecurity event brings together over 1,000 global experts, researchers, and policymakers to address pressing health security challenges, share innovations, and to shape resilient health systems. And this year, we'll be focused on biosecurity in the age of artificial intelligence. We're going to explore how artificial intelligence can ethically and effectively be integrated into health security strategies across the continent. So we are open for registration is open right now, and the call for abstract is also open. We invite researchers, practitioners, professionals to submit abstracts showcasing your research, your case study, innovative solutions in One Health, emerging infectious disease, AMR, climate change, biosecurity governance, and artificial intelligence. So you could visit our website at www.getafricaconference.org. It will be posted on the chat. And also, I would like to introduce you to Get Journal of Biosecurity and One Health. This is a peer-reviewed journal and it's a flagship publication of Get Consortium. It was established to provide a credible and Afrocentric platform for publishing high-quality research and policy analysis on critical issues at the intersections of biosecurity, health systems, One Health, climate change, and emerging infectious diseases generally, especially within the African context. So this journal brings together diverse voices, scientists, policymakers, public health professionals, and development practitioners to share innovative solutions, lessons learned, and evidence-based insights that can guide global responses to biosecurity threats. So we would like to invite you to submit your manuscript to Get Journal via the website at www.getjournal.org. The website will also be posted in the chat box. So right now, moving on to our third speaker for the day. It's my pleasure to invite it is my pleasure to invite Dr. Williams Dr. Kathleen Williams. And before I introduce her formally and give her the floor, I would like to read her biography. Kathleen Williams is the founder and principal of Mirror Insights, LLC, a boutique research, strategy, and advertising firm focused on advancing global health and human rights. Kathleen is particularly interested in how populist nationalist leaders and movements interact with health and health-related rights, curtailing access for some populations while expanding rights for others. Grounded in the sexual and reproductive health, rights, and justice movement, Kathleen work applies learnings from that arena to other areas of health. Previously, Kathleen has contributed to research with the World Health Organization, the Ghana Health Service, the Institute for Clinical Effectiveness and Health Policy in Buenos Aires and Argentina, the Latin American Center for Perinatology, Women's and Reproductive Health in Montevideo, Uruguay, and the University of North Carolina at Chapel Hill, and the Black Mamas Matter Alliance in the United States. She has also contributed to expertise to amicus briefs for cases in front of the Supreme Court of the United States, a memo to the U.S. Office of Civil Rights, and a statement to the Ways and Means of Committee of the U.S. House of Representatives. Kathleen holds a PhD and a MSPH in maternal health and child health from the UNC Gillings-Redder School of Global Public Health and a BA in Global Studies from University of North Carolina at Chapel Hill. She is a Royster Fellow and Robert Stone Scholar. So thank you very much, Dr. Williams. We are glad you are able to join us. Dr. Williams, the floor is now yours. Thank you.
Thank you very much. Thank you for the warm welcome and for the very interesting conversation today. This topic is very timely. It's close to my heart, and I'm grateful for the opportunity to speak a little bit about this with all of you today. Let me see if I can share my slides. Are you able to see the slide deck?
Yes, please.
Okay, perfect. So today I'd like to build a little bit on Dr. Wilson and Professor Tomori's comments about the threats that populist nationalism poses to biosecurity and global health solidarity, particularly in moments of crisis, and more importantly, what it will take to protect and advance collective biosecurity in Africa and beyond. As we've heard already, rising populist nationalist sentiment is challenging global solidarity, particularly outside of the African continent, and multilateral health cooperation is increasingly politicized. And so the question that is being posed to us today is, how do we protect and advance collective biosecurity in this climate? So I want to start by defining what I mean when I talk about populist nationalism, because we've heard some slightly different definitions from Dr. Wilson and Professor Tomori, and I do think that these are terms that are under contest. And so just to ground my comments, I'll say that I'm intentionally using a broad definition. This isn't an issue of the right or the left, right? There are examples of populist nationalism on both sides. But what matters for us for the purposes of the conversation today is that populist nationalism is a political strategy to consolidate power. And it does this by foregrounding the nation state, but not just any nation state. The populist nationalist appeals to an imagined nation, defined narrowly by ethnicity, by class, by ability, or by family structure, and draws a hard boundary around who constitutes the quote unquote people. Anyone outside of this narrowly defined group of the people are cast as elites, and they're threats to the people. Global cooperation, especially multilateralism, is framed as working against the people's interest even when it concerns shared priorities like health and biosecurity. And I really appreciate Professor Tomori's point about the distinction between populist nationalism and personality populism, and that personality populism is more the political strategy that you see across Africa, as opposed to populist nationalism, which in this moment we've really seen rise in the West. And I think that that's part of what's driving the different responses that we're seeing to this particular global moment, as I'll talk more about in the second half of the talk. But within this worldview, populist nationalism fundamentally takes a zero-sum approach to international relations and to any kind of politicking. It has to be the imagined nation first and everyone else last, because with this worldview, it is only possible for there to be one winner. And so following this logic, anyone supporting multilateral engagement, international cooperation, or global solidarity is automatically cast as part of the elite working against the interests of the people, even if the things that they seek to advance are objectively in the people's best interest. And so in the face of this rising tide of populist nationalist sentiment that we see globally, one that's undermining global solidarity, even when public health is at stake, we need to ask how we protect and advance collective biosecurity. Now, before I jump in, I do want to sound a note of caution about the framing of health security. There are some limitations to the securitization of global health that can play into the hands of populist nationalists if we're not careful. So first and foremost, the global health security framing positions global public health as a matter of national security. And through the zero-sum approach of the populist nationalism, the biosecurity of one country can only come at the expense of that of other countries. So for example, my country can only have enough PPE for health workers if I hoard personal protective equipment and make sure that your country doesn't get any, right? So biosecurity also becomes another rationale for scapegoating and attacking people who are not part of the imagined nation. So ostensibly, xenophobia is now justified because migrants may be bearing disease. We've seen this during COVID-19, we've seen it during Ebola virus disease, we've seen it with Mpox. And second, health securitization historically has been a way to steer the global conversation away from broader primary health care and universal health coverage agendas, which require global solidarity, towards bioterrorism and other high-income country priorities. We know that effective pandemic preparedness and response hinges on having high-functioning and resilient health systems, drawing on the tremendous expertise across the continent for public health surveillance and response. But in multiple pandemics, improving health security has been used as an argument to reroute funding streams into vertical silos rather than supporting horizontal health system strengthening efforts. And for the populist nationalist, this is an opportunity to move funds earmarked for health into national security, where they can more directly advance the political agenda. Now, none of this is to downplay the importance of global health security. To be clear, global health security is a critical component of global public health. But we're best able to advance global health security within strong multilateral frameworks of global solidarity and strong public health systems, as this audience is well aware. So I know I'm telling you things you already know, but I just want to kind of give us this framing before we jump into the rest of the conversation. So despite these challenges, there are two key pathways I'd like to discuss today to reinforce global health solidarity. First, through WHO, and then second, through other mechanisms beyond WHO. So first, through WHO, amid a crowded landscape of global health actors, WHO remains the sole entity mandated to direct and coordinate global health efforts. Global solidarity and the right to health are foundational principles embedded in WHO's constitution. So WHO's contributions to biosecurity in Africa are operational, they're normative, and they're strategic. So tools like the Joint External Evaluation allow WHO to help countries assess and strengthen capacities in biosecurity or biosafety, laboratory containment, and management of dual-use technologies. And many African countries have used these assessments to develop their national action plans for health security. WHO also facilitates negotiations on pathogen sharing frameworks, such as the Pandemic Influenza Preparedness, or PIP framework, and the proposed Pathogen Access and Benefit Sharing System, or PABS system. And these mechanisms provide African governments and research institutions opportunities to influence how biological samples are shared and how benefits are returned to source countries, so that it's not, as Professor Tomori said, that Africa has the pathogen and the rest of the world has the vaccines, right? And additionally, WHO supports countries through regional offices, deploying technical advisors, offering training, and conducting simulation exercises. And the Global BioHub system, currently being piloted by WHO, aims to create secure, transparent pathogen sharing mechanisms with African reference laboratories poised to play key roles. So the opportunity here is twofold. First, integrate WHO's tools into domestic systems to build lasting institutional memory that is independent from donor cycles. And second, to engage strategically in global governance processes such as the Pandemic Agreement and international health regulations amendments to ensure that African states shape biosecurity rules governing emerging threats. So WHO, in this sense, isn't just a support mechanism. It can be a platform for African leadership. In the face of ongoing populist nationalist threats to multilateralism, this past week's World Health Assembly has reaffirmed WHO's critical role and the importance of global solidarity. Member states voted to increase assessed contributions 20% to help fill the funding gap left by the US's intended withdrawal. And following Nigeria's leadership, a resolution was adopted to strengthen domestic health financing. And notably, the Pandemic Agreement was adopted with 124 votes in favor, 0 objections, and 11 abstentions. And the agreement highlights strong health systems, a One Health approach, and global health solidarity, in contrast to some of the global health securitization framing that I discussed earlier. It includes provisions on local production and technology transfer, which are critical to safeguarding Africa's biosecurity. And with many PABS system negotiations still under, or mechanisms still under negotiation, this is a pivotal moment for African institutions and negotiators to ensure equitable, enforceable benefit sharing frameworks that are responsive to countries' needs. So that's kind of through WHO. Now I want to talk about some of the mechanisms outside of WHO. The Global Health Security Agenda remains a key platform to strengthen national and regional capacities against infectious disease threats. Complementing the IHR, the Global Health Security Agenda emphasizes country ownership and multi-sectoral engagement, involving both the public and the private sectors, and positions biosecurity as a development priority rather than solely an emergency response. And for Africa, GHSA has catalyzed multi-sectoral collaboration and elevated health security to a national and continental priority. And while progress has been made in surveillance, workforce development, and national action planning, implementation has varied. The next step is to move from donor-driven compliance to sustained sovereign investment and embedding GHSA principles into domestic health systems, regional centers like Africa's CDC, and cross-border collaboration under the African Union. As new risks emerge from climate change and dual-use technologies, GHSA must evolve beyond preparing for the last pandemic towards building resilient systems for the next unknown, with Africa's scientific and political leadership at the helm. There's also opportunities through the African Union and Africa's CDC. So the African Union, through Africa's CDC, has become a defining voice in continental biosecurity, shifting from recipient to architect of strategy. And the AU's coordinated COVID-19 response, including rapid deployment of responders and the African Medical Supplies Platform, demonstrated that the AU has not just logistical competence, but it has strategic sovereignty that it's putting into action. Post-pandemic, the AU is leading initiatives such as the Partnership for African Vaccine Manufacturing, which is aiming for 60% domestic production by continental production by 2040, and the African Epidemics Fund for Sustainable Emergency Financing. Africa CDC has also developed a continental biosafety and biosecurity framework and is investing in integrated surveillance and early warning systems. And politically, the 2022 AU Common Position on the Pandemic Accord united 55 member states around equitable access, local manufacturing and sovereign data control in ways that we see reflected in the draft of the pandemic agreement that was approved last week. This is biosecurity diplomacy at scale, and it signals that Africa will not merely participate in health governance, global health governance, but will actively shape it. A vital complement to this is the proposed Africa Medicines Agency, which is a treaty-based regulatory body to harmonize medical regulation, strengthen pharmacovigilance, and accelerate access to safe, effective medical countermeasures. And the AMA will streamline approvals during outbreaks and curb substandard or falsified medical products, which are major public health and biosecurity threats, even outside of pandemic contexts. The AMA could also oversee safe handling of sensitive biological materials and dual-use research, working with national authorities. But its success depends on political commitment, technical investment, and alignment with Africa CDC priorities. But the potential here to link health innovation, regulatory agility, and pandemic preparedness is significant. And outside of this, we also see country-to-country and regional collaboration continuing to grow. Last week, Chad, Djibouti, Ethiopia, Somalia, South Sudan, and Sudan signed an MOU addressing visceral leishmaniasis, establishing a joint strategy for surveillance and control across the region. And 12 countries, including DRC, Angola, Kenya, and others, agreed on stronger cross-border cooperation on Mpox and other health emergencies at a regional meeting in Nairobi, also last week. And so these agreements represent a quiet but powerful resistance to populist nationalist retreat, showing that African countries choose collective action when aligned with shared public health goals. And so regional and country-led initiatives offer targeted collaboration that advances global health solidarity while meeting biosecurity objectives. As we consider the future of biosecurity and pandemic preparedness across the African continent, there are several areas where continued attention and partnership could help sustain momentum and strengthen collective resilience. The first is encouraging continued engagement in global health governance. So it may be helpful to support and facilitate ongoing African engagement in key multilateral processes, particularly as these frameworks continue to evolve. So the pandemic agreement and its forthcoming PABS system offer a timely opportunity for African negotiators and institutions to shape mechanisms that operate globally so that they function and serve the needs of African countries. And similarly, participation with the ongoing rollout of the IHR amendment process, continued engagement with the PIP framework and the global biohub system will be essential in ensuring that these platforms reflect a diversity of regional perspectives and operational realities, right? We need to make sure that these platforms are fit for the various different realities across the continent and not just some. Second, it may be useful to continue to invest in implementation of the global health security agenda. So GHSA has provided an important platform for strengthening capacities, as I've briefly touched on, and many countries have used it to conduct evaluations, develop action plans, and prioritize preparedness. But African leadership in GHSA needs to be reinforced, not just rhetorically, but through action. This could look like continued support for countries as they implement national action plans for health security, including peer exchange, financing strategies, and institutional strengthening. And efforts to align GHSA activities with Africa CDC's regional strategy may help to reinforce coherence and reduce duplication. There may also be value in exploring how GHSA frameworks can be better integrated into broader health systems and development planning, rather than operating as standalone initiatives. Third, global partners must recognize the African Union's evolving role as a governing center of gravity for health security. Right? This means there needs to be continued support for Africa CDC, especially for its surveillance, workforce training, and biosecurity frameworks. There's a need to accelerate the operationalization of the Africa Medicines Agency Treaty. So that looks like approval and ratification of the treaty, and then operationalization of the AMA itself once the treaty enters into force. And this will be critical for emergency regulatory readiness, pharmacovigilance, and in controlling the spread of falsified medicines across the continent. And most importantly, there is a need for international partners to recognize and fund African-led priorities, like the African Epidemics Fund and the Partnership for African Vaccine Manufacturing. These are expressions of strategic sovereignty and global solidarity, and international partners should get behind them. Fourth, regional cooperation needs to be viewed as a core strategy, not a backup plan, right? So bilateral and sub-regional agreements, such as those on visual leishmaniasis and mpox, are examples of innovation in global health diplomacy and should be celebrated. These arrangements allow for African countries to lead with context-relevant solutions while building resilient health systems that transcend borders. And international partners should invest in these regional public goods, including shared laboratories, surveillance infrastructure, and joint procurement platforms. In short, this is not a moment for retreat. It's a moment to double down on collective action and to reinforce Africa's leadership in global biosecurity, to strengthen continental institutions, and to build the cross-border alliances that populist nationalism seeks to dismantle. This is not just about preventing the next outbreak. It's about building a global health system rooted in justice, mutual accountability, and shared sovereignty, where no country is forced to choose between national survival and global solidarity. Thank you very much for your time and attention, and I will hand things back to our moderator. Over.
Thank you, Dr. Williams. Thank you so much for that fast-forwarding and strategic perspective. Your focus on inclusion, resilience, and practical policy direction is exactly what we need today in this conversation. So you mentioned a few things which I would like to re-emphasize. You recommended some things. You said we should encourage continued engagement in global health governance. You also mentioned we should continue to invest in implementation of the global health security agenda. And you mentioned we should support AU institutions and continental frameworks. And lastly, you also mentioned we should scale up regional and cross-border agreements. So that was a beautiful presentation. Thank you very much. So right now we'll be moving on to the final speaker for the day in person of Professor Kelly Lee. And before I before I call her to start speaking, I would like to read a biography. Professor Kelly Lee is a trained international relations and public administration with a focus on international political economy. She spent over 20 years at the London School of Hygiene and Tropical Medicine, where she co-established the WHO Collaborating Center on Global Change and Health. She was a core member of 2 donor-led studies of WHO reform during the 1990s and led the Guildford Archiving Project to secure public access to internal tobacco industry documents of British American tobacco. She was chaired the WHO Resource Group on Globalization, Trade, and Health. Her research focuses on collective action to manage cross-border health risk. Our current project focuses on strengthening pandemic prevention, preparedness, response, and recovery. This includes leading the pandemics and border projects on the effective use of travel measures during public health emergencies, and the Bridge Research Consortium to support public trust and equitable access to new vaccines and immunotherapies as part of the Canada's Immunoengineering and Biomanufacturing Hub. She's currently a commissioner on the Lancet National University of Singapore of Brinda's Pandemic Readiness Implementation, Monitoring and Evaluation Commission, on the editorial board for the WHO Global Report on Economic and Commercial Determinants of Health. She recently co-chaired the Royal Society of Canada Canadian Academy of Health Sciences Expert Panel Report on Canada's role in global health. She has published 15 books, 250 plus papers, over 60 books chapters, including a co-editor of the Oxford Handbook of Global Health Politics, 2020. She is a fellow of the UK Faculty of Public Health, Canadian Academy of Health Science, and Royal Society of Canada. Thank you very much, Professor Kelly, for honoring our invitation. We appreciate you. We are excited to hear from you. You have the floor, please.
Thank you. I'm trying to share my slides, but I don't have permission to do so. There might be an adjustment on the on Zoom that will allow me to do that.
Yeah, you can do that now.
Okay, thank you. Yes. I hope you can see the slides now. So thank you so much to the GET Consortium for inviting us all to come together in this timely conversation. Thanks to everyone joining from around the world. It's very nice to read in the chat everyone where you're joining us from. And it's difficult to follow three very insightful talks. I'm very grateful to the other speakers for clarifying key terms and for really digging down in some of the current challenges in global health governance that we're facing and its relevance to the African continent in particular. My brief presentation is broader and will focus largely on what we've learned from COVID-19. And I'm going to talk a little bit, as I was asked, about this tension between nationalism and globalism, and to try and see if we can find some ways forward in terms of the role of global health diplomacy. So I just wanted to acknowledge that I'm joining you from the unceded traditional territories of the Coast Salish peoples, who are Indigenous peoples in Canada, including the Tsleil-Waututh, Coquitlam, and Squamish and Musqueam nations upon which our campus sits. And I want to begin with this photograph, which really struck me, and I'm sure you've seen it. This happened just a couple of weeks ago in Geneva. And it's the vote in the World Health Assembly for the pandemic treaty. And to look at this photograph, first of all, it just gives me chills after all that we've been hearing about today, and you know, the experiences around the world. The amount of countries that got behind the treaty was really reassuring. At the same time, if you look at this photo, you would think, well, this is great. And this must have come from the fact that we were all so in solidarity during COVID-19. And that was just, you know, a logical conclusion that we reached a pandemic treaty. And of course, you know, we saw this message play out initially during the COVID-19 pandemic. We were told that we were all in this together. This message was given around the world in all countries. But the reality was that we were incredibly divided, that we became incredibly divided during the pandemic. And what's interesting about these photos is that this opposition, I guess, this increasing discontent came from both the left and the right of the political spectrum. The top right photo is in the US, and it's the sign that this man is holding up refers to a politician who is a Republican in name only, which is what RHINO stands for, who has the man who's holding the sign clearly has a distrust for anyone who he describes as a globalist. So that's one face of the opposition during COVID that emerged. And the bottom left photograph is a group of people who are demonstrating on the lack of access to vaccines for many parts of the world, which is what we've just discussed in the previous speakers' presentations. So what's important to recognize is that this feeling or sense of national division was not worldwide. There were some countries that were more divided than others, and this bar chart on the left suggest some of the countries that became more divided and some of the countries that became more united. And within each country, you had people feeling differently. So within countries, there was difference of opinion, and also there was variation across the world. So in general, very broad terms, European countries, North American countries, most people felt more divided during the pandemic. And in countries such as the East Asia, there was a majority of people feeling, in most cases, although some countries like South Korea and Japan felt more divided, but on the balance, people felt more united. And as I say, even within countries, you had difference of opinion whether countries were more divided or not. And this is just a chart from the BBC, which describes, how many people thought that the pandemic had deepened divisions and how many had brought people closer together. So there's an even split virtually there. So at the global level, which is what we're focusing on to some extent, this is played out in a lot of different opinions about how do we go forward from that? Do we need stronger global health governance mechanisms, such as formal treaties, agreements, collaboration across countries, or is there something else that we should be concerned with? And the people here who are demonstrating in Geneva are clearly very, very skeptical about moving towards a more global cooperation. They're holding up signs which are very distrustful of the pharmaceutical companies and about globalist elites. And this is something that, of course, has come up in the previous talks. So let me just take a step back and, given this kind of description of what's been happening, think about terms as well, because words really matter in how we define them. And if we go back and we ignore, first of all, what others think they mean by these terms when they're protesting, I just wanted to take a step back and talk about what is globalism. And in political science, it is basically the idea that the world's economies, cultures, populations, even perhaps political cooperation is increasingly interconnected. So our world is increasingly interconnected through processes of globalization. And the idea is that these ideologies and policies that drive the globalization process leads to a confirmation of globalism. And what this idea posits is that international cooperation is more important than national interests, and that the world is increasingly interconnected, and that is I think, the implied that this benefits all people. So that's the ideal under globalism. Nationalism, as we've heard already from the other speakers, is the perspective that members of a nation have a shared identity, and that this might be a geographical nation, it might be based on ethnicity, but you have a shared identity and a desire to achieve self-determination. And so when you promote the collective interests of a nation or a state over the interests of individuals, groups, sub-regions, groups beyond the state, and you're trying to advance the interests of that group, that is described as nationalism. I probably didn't do as good a job as the other speakers, but that just gives you a sense of the kind of different sets of perspectives that are behind these two terms. What has happened today is that the two terms have become very contested and very in opposition of each other. So you have signs such as this. This is a small political party in Ireland who have put up this poster. The virus is globalism, the antidote is nationalism. And you can find a lot of this behind populist movements. That is this retreat from globalism. So I'm someone who has studied globalization for many decades. I started my career studying globalization and what it means for human health, population health, What does it mean for health equity? And another definition, I'm afraid, globalization is the process by which businesses, ideas, cultures spread across the world and create these interconnectedness that underpins globalism. And it causes countries to become more interdependent with each other. So everybody is depending on each other. And what drives this is finance, but certainly not just financial connections, but also information, cultural connections, technology, and so on. But the general sense is that the world has become more interconnected since the late 1980s in particular. So over many decades, we have now a very globalized world. And there are, of course, many types of globalization. It's not just financial, as I mentioned, and the various types of globalization are listed on the right there. But the one that has become more problematic, and I guess the center of attention in terms of the conflicts that we see, political conflicts, is economic globalization. So there was the idea that as countries become more interdependent, there's more trade, there's more investment, there's more capital flows, that this is going to lead to higher generation of wealth and a more, a more robust world economy where there's greater efficiencies and so on. We've heard all this, of course. We haven't heard this for many decades. The ideals of what will come from this process. It boosts economic activity and productivity, and that eventually you get access to greater goods and services. The downsides are, of course, that what we've seen is wealth inequality. We've seen fears about cultural homogenization, so the loss of the diversity of cultures around the world. And there's deep concerns about domestic industries. So when globalization was unfolding, the idea was, well, then we could, kind of balance the two and integrate the two and have something called glocalization, where you take both sides into account and so globalization unfolds differently in different countries, different communities. The reality is that has, not happened very well. And so we often heard about the rising tide lifting all ships, and said, okay, just allow globalization to unfold, and eventually everybody will benefit from it. And I see, and you can see in this cartoon, we're still waiting for that rising tide to lift all ships, or in this case, the main ship gets bigger and bigger and more controlling of the wealth that has been generated. Another argument with globalization, economic globalization, is that there would be a trickle-down effect. That yes, there would be wealth generated, and eventually it would trickle down to benefit most people, all countries. The reality is that there has been a highly concentrated concentration of wealth in the world and of income. We see this every year with the Oxford reports, that there is, a smaller number of people controlling a larger proportion of the world's wealth. So these expectations about globalization have not played out. And what we really see in reality are these, impoverishment of what were formerly industrial sites in places like the US. That's a photograph of the Rust Belt, which is literally very rusty, old industrial equipment. But you don't see, you do see jobs created in other parts of the world, but they're not fantastic in terms of working conditions and wages and so on. And what I wanted to show was that, there's this idea that somehow jobs have been stolen from high-income countries, have gone to low and middle-income countries. The reality is that there's exploitation across the board. There's low wages, there's terrible working conditions, and the wealth that's being generated is certainly not being received by those workers who are around the world working incredibly hard to produce the goods that we see. And so what you're seeing as a result of all this process, and I totally simplified it, I have to admit, But what we're seeing is a backlash from that, from both the left and the right, about this economic globalization process that promised so much and delivered so little for most people. Delivered a lot for some people, a very small minority, and delivered so little for most people. And again, across the political spectrum, obviously they're protesting different things, but the commonality is that they're unhappy about the processes that have taken place. And we see this reflected in many of the surveys that are conducted around public trust. So we have, this is called the Edelman Trust Index, which many of you probably heard of, and it just sets out different aspects of public trust in 22 countries, I believe the survey is conducted, including Nigeria. You know, who do people trust? And what is your, you know, what are your sources of trust? And how do you feel about various institutions in society? And what it generally shows is that there are countries where there is high trust still, relatively high trust, but the numbers are not exactly, overwhelming. There's still a decline in many of those high trust countries. There's average trust in many countries and low trust in many countries. And the general trend is towards lower levels of trust overall. And so in the context of what I just described about economic globalization, we can make sense of that. And we see this in some of the Edelman questions that are asked of people. People are very worried about their employment, their job security. They certainly aren't very trusting of globalization. They feel very threatened by that. There are economic pressures that are felt around the world, and they're fearful of technology, which is probably led by artificial intelligence, but technology and more generally that replaces human capital. And what's also important to recognize is that there's a high distrust of our leadership. And this was touched upon by Dr. Tamori already about, you know, this idea of concentrated leadership in a particular personality. But even in countries where this is not happening, what we're seeing is a high level of distrust, that people feel like they're being misled by not just government leaders, but by business leaders and by even the media. So these are all very important trends that those who are in power need to take note of. And then finally, we're living in in societies where there's just a very high level of feelings of grievance towards these institutions and towards particularly the wealthy. We're seeing very high levels of unhappiness that is being played out sometimes in elections, sometimes in protests, and just simmering in terms of this sense of unfairness, of inequality, that the system itself is not serving the needs of people. And this is obviously playing out in different ways in different countries, different continents, but the general trend is towards higher levels of feelings of grievance. And so in that context, what we have when we're talking about today is global health security and essentially what global health security is. And I agree with Dr. Williams that it's not my favorite term in describing a lot of these problems. How I see it is that globalization has been happening over decades. It's kind of like a bubbling cauldron of things going on. And out of that cauldron will come, of course, a lot of positive things, but also a lot of collective action problems. And collective action problems are essentially those where countries need to work together to solve them. They cannot be solved by one country alone, not even one region alone. These are sort of global collective action problems. And what we need to solve these sorts of problems is not to act individually, like those fish on the left who are swimming around being chased by a big fish, but to coordinate, to collaborate in a way that enables those fish to turn the tails on the bigger fish, to really be more impactful. And global health diplomacy is the way that happens. So that reality has not changed. We still have problems that we need collective action on. But when we look at how global health diplomacy is conducted, it reflects a lot of the challenges that people see when they're feeling aggrieved, when they're feeling that the system is not serving their needs. So this is a really useful diagram from Rebecca Katz and her colleagues who talk about, this core global health diplomacy, which we heard quite a bit about in the previous speakers, about the formal negotiation of treaties, in IHR revision, and so on, conducted by heads of state or public officials who go to Geneva and they meet and agree these agreements. Then we have at another level, multi-stakeholder global health diplomacy, where there's lots of different interaction between different agencies, between different country ministries, and different actors. And then partnerships are formed and important work is done, or at least tries to be done. So there's these multilateral. Then there's a lot of unofficial, informal global health diplomacy that happens. Interactions between many who work in the public health sphere, medical doctors, who many are on this call, who are trying to implement a lot of the agreements that are taking place. So that happens at a much more broader number of people. And, in their entirety, this more from formal to informal, we can consider this global health diplomacy. But what I noticed in this diagram is that right at the bottom and kind of, at the last thing mentioned is the public right at the bottom. And, it made me think, is this part of the problem that the public doesn't even know what's going on in a lot of this diagram? They hear in the news, a treaty's being negotiated. They hear about their leaders, which they're not too trusting of. They hear about business being involved. So they feel very excluded from this global health diplomacy process. And they're not very engaged, not very informed, not very involved. And this is maybe part of the problem. Just add to that an information environment which is in serious decline. So we have a lot of interpretation of what's happening in either a mistaken way, misinformation, or a deliberately inaccurate way, which is disinformation. You also have just a lot of information being put out. People are trying to process. So we have this infodemic that's happening. But there's lots of concerning, I guess, problems with the information that we're receiving, whether it's too much, whether it's unfiltered, whether it's quality control. There's many, many problems that are really feeding into a lot of the discontent. And so this is leading to conflict. And so you have people, kind of lining up behind one or the other. And what we're seeing the narrative now is that you have nationalism being championed either from the left or the right as more preferred in globalism, and we need to get away from globalism. So for me, it's not really supposed to be a direct kind of fight between the two, but really it's about balancing the two. And this is an age-old balance. When do you cooperate and when do you not cooperate? When do you put your country first? When do you put humanity first? These are really fundamental philosophical questions, and it's not one or the other all the time. There's always a negotiation. There's always a balance that has to be achieved. And ideally, if we can achieve them both at the same time, that's when we get the most buy-in from countries, from the public. And so where we're at in the world, I think, historically, is that we're in a very difficult place politically. Humanity is facing that bubbling cauldron and many, many other issues related to the world. Climate change comes to mind most. But we have political institutions that are so out of date, so unrepresentative of people, that we see this backlash that's happening. So there's a lot of thinking among political scientists and others around how do we innovate politics? How do we create a political I guess, political institutions and practices that really get over this very polarized environment that we're now in. And that starts with in addressing this information environment. So there's a lot of discussion around how do we clean up or how do we raise the quality so that we have a healthy information ecosystem that allows us to discuss these issues in a civil and informed way, unlike the kind of rather toxic environment that we're now facing in many countries where these issues can't even be discussed. So that's one, I think, first step. The other is to recognize that public trust is incredibly important if we're going to get anywhere in terms of collective action. And there's been a lot of thinking around what is public trust and what do we mean by, you know, what are we aiming for? And the main thing I would say, and it's just like a huge lecture in itself, but I would say that we need to get away from the fact that it's not just you either trust or you don't trust. Those are the two extremes, but that we all have a mixture of the two. And it can range from distrust, you know, suspicion of everything, and you're just not going to believe anything that somebody says, to blind trust, which is equally, I think, dangerous. And we're seeing this being played out in the US at the moment, where there's just a deference to an individual or to a party with no critical thinking, no critical reflection. What we want is people to be in the middle. You want, you know, of course, we want people to trust their institutions. We also sometimes want them not to trust their institutions because there has to be accountability and transparency. We have to be able to make decisions in an informed way and be critical of our, use critical judgment skills. So those are the kind of things that we're trying to move the public towards. I think we're struggling because of that information environment. And I'm coming near the end, but I would say that it's often said that science is the way that we move from, you know, away from this this kind of trust problem. Science is one thing, but values is really fundamental as well. So it's not just about an argument about facts. I think most people would say that they actually believe in science. What they think of as science is probably different, but also what they value. And those are things that we need to also have important civil discussions about. We can have different values, but we need to be open about them and negotiate them. So I'll end by saying that, you know, this photo at the beginning seemed like a wonderful indication of how unified we are in the world around the pandemic treaty. What it is really is it's fundamentally a treaty that has tried to negotiate that path between globalism and nationalism. Some would argue that it's actually so watered down that we actually have a very nationalistic treaty. Others say that there's glimmers of hope and opportunity to negotiate stronger on some issues and therefore a symbol of globalism. But I think that's where we're at in the world. And I would just summarize by saying that for global health diplomacy, there are a number of lessons. First of all, that a pandemic event like COVID-19 was really supposed to bring us closer together and to work closer together. And instead, for many people in many places, societies became more divided. And this tension between globalism and nationalism explains a lot of the tensions that have come to the fore. But not just COVID-19 that caused this division to emerge. What we have to do is think about historically how globalization has unfolded, that has put us in a position when COVID-19 came along to be less able to come together. And we see this in the left and right-wing populism, that what we see are failures to serve the needs of the many over the few. And so globalism is a word that's become untrusted, mistrusted, and probably distrusted, and nationalism has come to the fore. And finally, in principle, what we want is still global health diplomacy. It's something that we need because we still have those collective action problems. And we still have some forms of globalization, even if some countries are trying to pull back from them. But what we don't have is the political institutions that we need So we have political shortcomings, and we have, as a result, declining public trust. So we need some innovation in thinking about global health governance, as well as probably broader global governance and national governance that re-engages the public. We can't keep ignoring people. We need to have a deeper understanding of the continuum of trust that and where we want people to, or how we get people to be trusting again in a critical thinking way. And we need to reframe globalism and nationalism, not as opponents, as somehow we need one or the other, but we have to get them both right in terms of the world we live in. We need a better balancing act. And that means also a better negotiation of our diverse values. I'll stop there, but thank you very much for listening. Hand it back to the our host.
All right, thank you very, very much. That was a thought-provoking discussion, and thank you for helping us connect history, diplomacy, and the future of collaboration. And there were things you mentioned that really caught my attention. You said we need to ensure a balance between globalism and nationalism, which is how we can, that is the key for collective action problems. And you call it localization. And I also agree with that. And I believe that's the way forward. We should always have a balance between the two. At times we need to go global, at times we need to limit it to our national level. So thank you very much, ma'am. Because of our time, we would like to move on to the question and answer session. And I can see we have quite a number of questions here, although we might not be able to take everything, and some of them have been answered. But the first question is, can you tell what about a relationship between the standard of living and epidemic disease? I don't know if anyone wants to answer that.
Sorry, what was the question again?
Okay, can you tell what about a relationship between the standard of living and epidemic diseases?
Well, can I just come in? Native intelligence. Cleanliness is next to godliness. Disease outbreaks are not around godliness. By that I mean, if you have a clean environment, the pathogens are not there for you to take care of. I mean, take the issues. I give a good example. Take Lassa fever, for example. We spread it because the rodents invade the homes. The homes are dirty, and therefore, you have more rodents in, and they increase the contact between man and rodents, and then Lassa fever. And that's why we have these big upsurges of cases in Nigeria, apart from the fact that, the rodents also have to move from one place to another. So the cleaner environment, take issues of mosquitoes and malaria, or take issues, anything that mosquitoes bring around, arboviruses, malaria, whatever they transmit. If you have pools and water around your house, you're not taking care of your environment, you breed more mosquitoes, and you get that. So standard of living is quite important, and whether you get an epidemic or not. And standard of living, and the standard of living is also gives you a preparedness. If you're all trying to find out what to eat, what to find, you don't care too much about the environment. If you're not sure where your next meal is coming from, and if you have a government that is not doing what it should do, and the lower standard of living around the environment, that's why most of the epidemics we have in Africa are coming from the rural areas where we have neglected. I'm sure others have comments to make, but I'm just taking it from my own background.
Yeah, I think I'll maybe just say a couple of things more broadly. Obviously, there's a link between the impact of infectious diseases and standard of living, and with food insecurity and such contributing to greater morbidity and mortality. But I think there's another perspective. Individuals in countries that have lower standard of living may not see the manifest benefits of some of the global arrangements. So I give the example of the UK and Brexit. One of the advantages of Brexit, of the EU, was the EU passport and traveling through countries unfettered. Individuals with a lower standard of living in the UK see that that's no benefit to them, and this may, again, to their perspective, not sort of further their distrust of these type of systems.
Right, thank you very much for the beautiful answers. I would like to invite Dr. Ayo Totunbobadoye, the Chief Operating Officer of GET Consortium, to please take it up from here. Thank you so much.
Yeah, good afternoon, ladies and gentlemen. I don't know why Faith is bringing me home. I'm in another meeting, a very important national assignment. Well, let me just thank our presenters for the presentation today. I am sorry I couldn't listen to any of the presentation because of the meeting I am. But to round up, I just want to say this. COVID showed the world clearly that a challenge in anywhere in the world, if not properly handled, may become a global challenge within a short period of time. And that is why international solidarity is very important in handling emerging health challenges, especially pandemics and epidemics in our world today. But having said that, it is very clear too, and I believe that nobody should support to fund anybody's irresponsibility. And it has become very important for every country, whether developed or developing country, to sit up and make sure that they take responsibility for funding health within their own system. Every country, especially countries in Africa, should sit up and increase funding to the health sector and make sure that not just increase funding, those fundings are not mismanaged, because mismanagement is one of the biggest challenge we are having in some part of the world. So it's very important. I believe that solidarity, global solidarity is very important, but also effective management of fund and effective funding of health systems using different innovative strategies is also very important for us to address emerging challenges we're having today in the health sector, especially in African countries. So I want to say a big thank you to our participants and to those that have joined this webinar today. Like I usually say, you are the reason why we organize this webinar every month. And thank you again. I hand over to Faith to conclude the webinar. By God's grace, we'll organize another one this time next month. Thank you.
Thank you very much, Dr. Dotun, for that. Right now, we would be rounding up the webinar, and other questions will be answered while we are sharing the certificates because of our time. So what a truly meaningful and insightful session this was. It has been very great, and we greatly appreciate our speakers. A outright thank you to our distinguished speakers, Dr. Coleman Wilson, Professor Yewale Tomari, Dr. Carlton William Schroeder, and Professor Kelly Lee. Thank you very much. We truly do appreciate you. Thank you for honoring our invitation despite your busy schedule and the time differences. We appreciate your time and contributions. And to our audience, like Dr. Johnson said, there is no webinar without you. Thank you for engaging, asking thoughtful questions, and being part of this important conversation. I would like to use this opportunity to invite you to the June edition of the GET webinar series. The topic will be shared across our social media platforms, so please do well to follow us on social media. Also, certificates will be shared to all registered participants alongside the speaker's presentation slides, if you are given the permission to do that. So thank you very much. We look forward to welcoming you again in the next edition by June. Until then, stay safe and bye. Thank you very much. Bye.
Thank you very much.